Hello, my name is Passarelli, and this is my presentation on endometriosis. Endometriosis is defined by endometrial tissue outside of the uterus. For the clinical patient presentation, we have a healthy 27-year-old woman that has come in and presents with worsening painful menstruation, otherwise known as dysmenorrhea. She has lower abdominal cramping and pain, as well as painful intercourse, which is called dyspareunia. She has regular menstrual cycles, however, she has been noticing that throughout her years, the lower abdominal pain increases upon menstruation and occurs several days after her period, and this has worsened. She has also expressed concerns about her fertility because of her inability to conceive. Endometriosis has no fully understood cause, however, there have been several theories indicating as to when women are diagnosed. The implantation theory was founded by John A. Sampson in 1921. His theory suggests that retrograde menstruation is the cause, and it occurs when menstrual blood and uterine tissue enter the peritoneal cavity by flowing through the fallopian tube. Affected women have immune dysfunction that prevents the clearing of implants. Implants in this situation are clumps of tissue that grow outside of the uterus. However, retrograde menstruation may occur in many women, and not all of them have endometriosis. It is when a large amount of fluid is found in the pelvis caused by retrograde menstruation that it increases your risk for endometriosis and it causes the lesions within the endometrium. The second theory, the induction theory, was founded by Levander and Norman in 1955, and it is based on the assumption that endometriosis results from differentiation of mesenchymal cells. Their function are basically stem cells that are found in bone marrow, which aid in the function of connective tissue such as the epithelium that surrounds the endometrium. They are activated by degenerating endometrium that arrives in places within the body where it's not supposed to. The theory of colimbic metaplasia, the third theory, was founded by Meyer in 1903, and it proposes that endometriosis comes from metaplasia of cells, or a change of cells to form that does not normally occur. This can happen in the mesenterial lining of the visceral and abdominal peritoneum, essentially suggesting that endometriosis becomes established in the peritoneum, and that a change of peritoneal cells into endometrial glandular cells will cause the disease. This can also be caused, however, by exposure to chronic irritation by retrograde menstrual fluid, which goes back to theory 1 of Sampson's retrograde menstrual fluid to cause endometriosis. The fourth one that has been kind of talked about within theorists is the fact of genetics. I didn't put a theorist there because people have been talking about it, but I would say these three theories are the most important when proposing why someone would have endometriosis. They are basically saying, in terms of genetics, that endometrial cells lay dormant and they're dependent on ovarian hormones, so when the ovaries start to work causing menstruation, it can then cause endometriosis within the body. In studying the background of endometriosis, it's important to acknowledge that while it is a painful condition that can affect your daily life, it is not a disease that will cause you to pass away. For example, even if you have stage 4 endometriosis, you may have deep implants, thick adhesions, and also maybe large cysts on your ovaries, but it's not going to cause you to die. If anything, there may be a life-threatening problem that can arise from your symptoms. Otherwise, you're just going to have severe pain. Essentially, endometriosis is estimated to affect 6 to 10% reproductive aged women. It is found in 50 to 60% of women and adolescent women with pelvic pain, and it is found in 30 to 50% of infertile women. Usually women with endometriosis are going to be infertile more than fertile. Their fertility rate may be lowered because of the fact that they have endometriosis, and it does affect 0.5 to 5% of fertile women. It's important to note that although 6 to 10% of reproductive age women have endometriosis, a lot of endometriosis is believed to go undiagnosed because they believe that it may be a differential diagnosis that they happen to be diagnosed with. The background of where endometriosis came from: Karl von Radikansky was the first to identify endometrial tissue growth outside of the uterus. In 1860, he had began studying diseases associated with the woman's uterus and ovaries. Specifically, he had studied abnormal tissue growth in the uterus, which he had uncovered during an autopsy. Upon studying different abnormal tissue growths, he had found that one uterine polyp resembled endometrial tissue from the uterus. He had wrote about his studying the abnormal tissues and his detections of the endometrial tissue growth outside of the uterus was one of the first detections of endometriosis. He had characterized it by abnormal growth of endometrial cells that line the uterus, called the endometrium. His studies and research, as well as writings, had allowed for researchers to further identify and work with endometriosis. One of the pioneers being John A. Sampson. We had previously talked about him in defining his Sampson's theory. He was one of the first people to come up with a theory supporting the pathophysiology of the disease. It was Sampson who had really studied the disease systematically, described the clinical manifestations, and contributed to the understanding of where the disease had arisen from. He had theorized that the obvious explanation for the uterine contents reaching the ovary and the surroundings was because of retrograde flow and menstrual contents through the fallopian tube. The theory was well received, especially because the disease process had never been studied in great detail. The majority of risk factors that have to do with endometriosis actually coincide with one another, and that has to do with risk factors arising from the menstrual cycle, or menstruation in general. So usually, starting your period before the age of 12, otherwise known as early menarche, having a very short cycle, less than 27 days, but in that 27 days of your cycle, people with endometriosis will experience very heavy periods, lasting longer than 7 days. And in that time of their heavy periods, their pain will be at an all-time high. It is also expected that prolonged exposure to estrogen or high levels of estrogen in the body, this occurs by either starting menstruation early or late, will increase your risk of having endometriosis. It is known that endometriosis commonly occurs in the presence of persistently elevated estrogen levels. So people with this disease, since their body has more tissue to shed, again, their periods may last longer, their cycles will be shorter, and menstruation will begin sooner than every 28 days. So during that time, they're experiencing a lot of pain and a lot of blood. Another risk factor is one or more relatives associated or having endometriosis. Despite these findings, there are really no genetic tests that can identify or predict the risk of endometriosis. However, there have been various genetic mutations that have been closely linked to finding whether someone has the disease or not. For example, there is a genetic mutation called 7p15.2, which influences uterine development that may be a small cause of why people are diagnosed with endometriosis. It is believed, though, that endometriosis is caused not by one but multiple genetic mutations, and again, it hasn't really been looked in that much to where they have a strong predictor of why people would get the disease. So the basics about endometriosis and its pathophysiology: endometrial tissue that is located outside of the uterus thickens, breaks down, and bleeds, which happens when you have endometriosis, makes so that the blood cannot exit and it becomes trapped. This is usually during the time of when a woman will go through menstruation. So during this time when the blood is trapped and it cannot exit, it creates a lot of pain. And during this time, or rather after, you can either form cysts or it will irritate and inflame. Usually it does both, but in severe cases it will form cysts. So let's just say it's a stage 2. Essentially, when the blood becomes trapped and cannot exit, it will cause irritation and inflammation, and then it will cause pain, severe pain during menstruation, and even possibly when not in menstruation. If it is a more severe form of endometriosis, such as maybe a stage 3 or stage 4, when the blood is trapped and cannot exit, it will cause cysts, and these cysts will cause scar tissue and adhesions, and then possibly cause infertility because of the adhesions in the uterus, making it non-possible for a zygote to be fertilized and grown. So pathophysiology continued. Endometrial implants occur throughout the body, but they primarily occur in the abdomen and pelvic cavities. So the most common sites of implantation of the nodules are the ovaries and peritoneum. So for example, when the nodules implant in the lining of the ovaries, it can cause a effect on its surrounding tissues or organs, and in this case it would be the fallopian tube. So that inflammation of the ovaries because of the nodules is going to cause fibrosis, scarring, and pain. And the same goes for the peritoneum. The endometrial cells or the nodules implant themselves in the peritoneal wall and cause inflammation and scarring. And that's where the majority of the symptoms lie when it is felt with endometriosis. It can also affect the deep endometrium. This is usually in like stage 4, I would say, of endometriosis, and that's when nodules implant 5 millimeters below the peritoneum, and it can cause surrounding tissues such as the bladder to be penetrated, to be inflamed, and to be in pain. Most symptoms of endometriosis can be explained by the growth, breakdown, and bleeding of endometrial tissue as well as adhesions. However, there are signs and symptoms that have different explanations, and one of those being dysmenorrhea. Dysmenorrhea is a sign that affects 50 to 90% of people diagnosed with endometriosis, and that is painful menstruation. In women with endometriosis, the lining that grows outside of the uterus, usually around ovaries or beneath the uterus, builds up and it breaks down, and this causes small amounts of bleeding inside of the pelvis. This leads to pain, inflammation, swelling, and scarring, which is a large majority of the reason why women with endometriosis have pelvic pain. Another symptom is dyspareunia. This is pain during intercourse. It frequently occurs with people or in people who have endometriosis because penetration and other movements associated with intercourse can stretch and pull at endometrial growths. This pain can either feel acute or can feel stabbing and severe, depending on which stage or what kind of growths you have outside of your uterus. The pain caused by endometriosis during sex is very deep, and it comes from inflammation and fibrosis fusing the front wall of the rectum to the back wall of the vagina. So the mobility and expansion of the upper posterior vagina behind the cervix normally occurs during sex, but it will not occur during endometriosis, which is the reason for the pain because of the non-consistent movement. Another symptom or sign of endometriosis is the inability to have a child or to be able to fertilize a child inside of you, otherwise known as infertility. Endometriosis can influence fertility in several ways, so this could be because of distorted anatomy of the pelvis, because of adhesions or scarring, scarred fallopian tubes, inflammation of the pelvis, altered immune functioning, and changes in the hormonal environment that affect the possibility of eggs or a zygote to be formed inside of the uterus. Other symptoms or signs can be fatigue, bloating. Bloating is caused by endometrial-like tissue that can cover or grow over the ovaries, and when this happens, it traps blood that could form cysts, which cause bloating. Diarrhea can occur in women with endometriosis because prostaglandins, which are released from the endometriosis implants in uterus, can cause smooth muscle contractility, which affects the bowels, and this increases contractility of the bowel, so diarrhea and cramping of the bowel can occur. With endometriosis, early diagnosis essentially means better management. So when a patient comes in complaining of their symptoms, usually a gynecologist or a doctor will first perform a pelvic exam. This is usually performed by just using their fingers on the exterior of the stomach, just pressing down, seeing if there's any tenderness, seeing if there's a pelvic mass that they can feel, or if they can feel immobile pelvic organs. A doctor might also perform a rectovaginal exam, which allows doctors to examine and identify abnormalities in the pelvic area, more specifically those of the uterus and ovaries, and it allows them, to feel deep inside the pelvis to determine how large those pelvic organs are, but also to see if there is actual pain that the person is having that they're not supposed to have due to their endometriosis. They could come to terms and be like, okay, we want to actually diagnose this and see the endometriosis within the body. So they'll perform a pelvic laparoscopy, and this is 100% required for diagnosis. This is a common procedure used to diagnose and remove mild to moderate endometriosis, and it's just a small incision in which a camera basically goes inside and views the internal organs and possible problems caused by the endometriosis, and also to see if they can remove anything that is causing the patient pain. If it's not diagnosed by pelvic laparoscopy and the doctor just does the pelvic exam, there can be a differential diagnosis. A lot of people with endometriosis are actually diagnosed differently, and actually do have endometriosis due to doctors thinking it's things such as complications of ectopic pregnancy, pelvic inflammatory disease, a ruptured ovarian cyst, IBS, or interstitial cystitis. Again, they'd be able to tell if it was endometriosis by performing the pelvic laparoscopy. Like I had mentioned before, the one way to truly diagnose endometriosis is a pelvic laparoscopy. However, an ultrasound may be done before in suspicion that someone is, going to be diagnosed with endometriosis. So this ultrasound, actually, you can see the cysts on the endometrial lining, and that's usually what the ultrasound is done for, is to identify whether there's cysts associated with endometriosis. I'm going to go over this slide briefly. This is diagnosis continued. This is just one of the great ways to diagnose or further diagnose what stage of endometriosis you have. This kind of reminds me of the classical coma scale that we talked about in class. It just kind of gives points, and obviously the higher the points, the more severe the endometriosis we have, to, again, further diagnose or put and pinpoint what stage of endometriosis someone has, usually based on a laparoscopy. So in stage 1, for example, in the peritoneum, it's going to affect the superficial endo, usually 1 to 3 centimeters. In the right ovary, it's going to affect the superficial endo, usually less than or equal to 1 centimeter, and 1/3 or less than 1/3 are going to be the size of the filmy adhesions on the right ovary. Kind of skipping over stage 2 and 3, let's go straight to stage 4. In the peritoneum, you're going to see more than 3 centimeters of the deep endometrium affected by endometriosis, which is going to cause that severe pain. In the right ovary, you're going to see the deep endometrium affected 1 to 3 inches deep, and you're going to see dense adhesions that are less than 1/3 of the size. In the left ovary, you're going to see the same thing. You're going to see the deep endometrium affected 1 to 3 centimeters, and you're going to see the dense adhesions that is less than 1/3. There are more that kind of qualify for how many points you get in stage 4, but those are the main ones. And I would say when it gets deep and when it really affects a large amount of length in either the peritoneum, ovary, or left ovary, that's when it really qualifies as a stage 4. And 2 or 3, it depends on whether it affects the deep endo, the superficial endo, obviously affecting the deep endometrium more as it continues on to stage 4. All treatments of endometriosis are aimed towards alleviating pain and possibly restoring fertility. So as far as medical therapy goes, NSAIDs, otherwise known as anti-inflammatory drugs such as ibuprofen, are easy and readily available pills for women to dumb down their pain. Now, it's not really known if it is going to be effective against their pain. However, it's easy, it's over the counter, and a lot of women will use it to alleviate some of their symptoms. For people who are more progressive or are at higher stages of endometriosis, the ibuprofen probably won't do anything. Oral contraceptives, ones usually with high levels of progesterone, are the most effective at stopping endometriosis pain, probably over anti-inflammatory drugs such as the ibuprofen. And continuous use of these pills to prevent menstruation can stop the endometrial cells from shedding and causing that inflammation and irritation, which is why they are used. There are surgical therapies that are used in order to alleviate pain from endometriosis, and one of those being a laparoscopy. A laparoscopy actually always needs to be done in order to diagnose endometriosis, and it's a very common procedure used to diagnose, and it also removes mild to moderate endometriosis. So instead of using a large incision, the surgeon just inserts a light viewing instrument called a laparoscope through a small incision, and if he needs better access, he can make more incisions, but essentially the laparoscope is just used to view the internal organs to look for signs of endometriosis and look for other potential problems as a way to diagnose. And he can also remove any visible endometriosis implants or scar tissue that may be causing immediate pain for the patient. A hysterectomy is surgical removal of the uterus. Now, this is not usually recommended unless you also get an oophorectomy. Hysterectomy is removal of the uterus, but oophorectomy is removal of the ovaries as well. So it's not 100% effective unless you actually remove the uterus and ovaries as well, because if you just do the hysterectomy, multiple surgeries may be needed and the pain relief might not be complete. but when you get rid of all of it, it leads to permanent sterility, triggers menopause, and your symptoms should be gone. There are a lot of people in the world that are not going to want to take medicine or have surgery in order to alleviate their symptoms of pain when diagnosed with endometriosis. Some people might go and look for alternative forms of medicine in order to alleviate their pain, and one of those is acupuncture. Acupuncture is essentially just small needles being stuck into the body that are believed to stimulate the central nervous system, and this in turn releases chemicals into the muscles and brain, and these changes may stimulate the body's natural healing abilities and just promote overall just better physical well-being in terms of when you do have symptoms, or even when you don't have symptoms. So the acupuncture practitioner will identify spots or symptoms in which are very individualized to the individual, and they will go and focus acupuncture on those places. So the acupuncture practitioner might also recommend nutritional therapy that could include herbal formulas, which is the Chinese herbal medicine. Those two kind of go and coincide with one another. Osteopathic medicine is a whole person approach to medicine. It's usually treating the whole person rather just the symptoms, which kind of focuses on preventative care. So doctors of osteopathic medicine, for example, might ask the person with endometriosis to focus on eating a diet that's high in fruits and vegetables. One of the risk factors, or one of the theories I would say, was that diets high in red meat could actually mess with your hormones and cause you to have endometriosis or cause a greater risk for developing endometriosis. So dairy and meat products have added hormones that may be linked with hormone imbalances in patients, and the nutrients from these foods, such as protein, vitamin D, calcium, and iron, are important components of a well-balanced diet. It's also important to have a diet high in fruits and vegetables, which may be recommended by a person who is within osteopathic medicine. This is my works cited. And furthermore, if you have any questions or issues with the presentation, feel free to email me or ask. Thank you so much for watching.